Well, I'm really excited to be here. This is not my first time here at this location. I've been here for other groups, such as the colon group and the breast ovarian group. And I'm actually really thrilled to be invited to come and talk to a group that have in common an interest in prostate cancer genetics, because I think prostate cancer genetics is really exploding right now. It's a really hot topic for everybody in genetics, and of course, everybody in urology as well. So, it's very timely that I'm here. So I am going to do my best in the time that I have allotted to cover a lot of topics. Most of my experience, as you just heard very nicely, Dr. Bowfinger, is really in the area of inherited genetics. So I have a lot of experience in looking at what genes cause a predisposition to a variety of cancers. But I'm also going to save some time towards the end of my talk to talk about tumor-based genetics. So looking at the genetic mutations or drivers in those tumors that change how you view that tumor as far as its prognosis or how aggressive it is or whether it's likely to metastasize. So I'll be talking on both, but I do want you to definitely know that my bulk of my experience is really in the inherited world. And it's an interesting thing to be in oncology right now, because we're really dipping our toes, in both of those ponds right now. And so, some people are having to learn one way and some people are having to learn the other, but we're all working together. Another theme, I think, of my presentation this evening is just basically that it's about time for prostate cancer to get some attention from the genetics world. I think it's always been there, but I'm sure you have felt the same, that there's a lot of like rah-rah breast cancer and rah-rah ovarian, and colon a little less so, because I guess nobody wants to talk about their colon, but similarly, I think it's time for prostate to get more attention in the genetics arena than it really has in the past. So with that, I will get started. I do have some disclosures for you, or acknowledgments, really. I don't have any. It looks like what's on the screen is not equaling what's on the big screen up there. All right, maybe Jim's going to help me out. But I want to let you know I have a few acknowledgments. And first, I did borrow some slides from another genetic counselor named Deb Collins at the University of Kansas, so I want to definitely thank her. I also was able to get some slides from the Myriad Genetic Laboratory, who offers the Polaris tumor test. And I also have some handout materials from a lab called GeneDx. So I'm not employed by any of these labs. I will be talking a lot about the labs, and I don't want you to feel that I have an affection or favor for one lab over the other, because a lot of them, in some ways are really equal. So I think hopefully it'll respond to me now. Oh yeah, there we go. So I'm just going to start with some empiric data, just to get our brains warmed up. I like numbers. You heard I have an engineering background, so I'm all about the numbers and the data. But I'm also all about the people, which is where my genetic counseling comes in. So I'm also just going to talk a little bit about the history of prostate cancer genetics, like where things have been for the last 10 or so years. What are the pivotal points where things are shifting, and where are we heading into the future with prostate cancer genetics? I want to talk a lot about NCCN guidelines. Are you all down with NCCN guidelines? When I say that, you know what I'm talking about? National Comprehensive Cancer Network, NCCN guidelines. So I want to remember to say at this point that I'm going to show you a lot of NCCN guidelines. This is what the doctors go to, when they're referring what's the standard of care for any type of cancer. And these guidelines are updated sometimes 2 or 3 times a year. So they're sort of a moving target, because there's a committee that's reviewing data all the time and deciding, how to make these changes. And it seems like if you just Google NCCN guidelines, when you pull that up, it seems like, only a doctor can, register here or something, but anybody can register. So I highly encourage you, if you've got a little extra time and want to explore this a little further, to just go to NCCN guidelines, register yourself, you get a little log on and a password, and explore the prostate cancer area, because it's a lot. There was no way I could even get through reviewing it in preparation for this talk. So I'm going to talk about NCCN guidelines, and then I'm going to end up with the tumor testing. So just to warm our brains up, talk a little bit about incidence. I think you guys probably know that prostate's very, very important when it comes to prevalence, and really it's number 3 here. It's very high on the list. So 10% of all new cases of cancer in the U.S. are going to be prostate-based. And when we look at the age relationship with that, there's a huge bump here where the median age diagnosis is 66. And it gets lower and lower and lower here, where it's really rare to see something before age 40 or 45. So, that's definitely early onset when I say early onset. You probably are also very well aware that folks who have a family history of prostate cancer have a higher risk. I'm going to go over some empiric data tables on that. And also that it's more common in the African American population, as illustrated here. It's a real outlier. And there are some areas, some ethnicities such as Asian and Native American who have lower rates than the average European U.S. person. So inherited risk for prostate cancer. So everything I'm going to say now for a little while is just based on empiric data. So it's not based on genetic testing or a mutation or anything like that. It's just based on looking at your family or looking at the makeup of your family and determining what's the risk for somebody else to get prostate cancer, develop it. So, we say this with almost every cancer, 5 to 10% are hereditary, but I think, they're more or less. And I think we're seeing some of the data with prostate cancer showing it's more hereditary than I think we originally thought. And family history is one of the strongest predictors of prostate cancer coming in your family. So here are 2 pretty good statistics that came up from Memorial Sloan Kettering Cancer Center. So if a man has one close relationship with prostate cancer, so like a brother, his relationship or his risk for prostate cancer is at least twice. And if you have 2 close male relatives with prostate cancer, then there's an increase 5-fold. So that's like a pretty easy statistic to think about. But it's also so important for the men in your family to be aware that they probably have an increased risk of developing prostate cancer compared to the average man out there. These are some even more in-depth risk figures, which you could probably find yourself somewhere in here, perhaps, or your relatives. But if you have a brother or a father with prostate cancer at any age, your relative risk, so that means how many times over the background risk is your risk, is either from between 2 and 3 relative risks, 2 and 3 times. If you have one affected first-degree relative, so first-degree relative is a brother, a father, a son. If you have a first-degree relative at any age, you're at about 2.5%. And if you split that out to younger people and folks who are over 65, you can see it's higher, obviously, if you have younger, and lower if you have older age of diagnosis. And you can even go out to second-degree relatives. So a second-degree relative would be like an aunt or uncle or a grandparent or a niece or nephew. And if you have a second-degree relative, the genetic component isn't quite as high. But if you have multiple first-degree relatives, I think this is about the highest number that you can get. So 4-fold over background. So you basically take 12% times 4, 48. Pretty high risk. Any questions so far? Yeah.
Yeah, 2 or more first-degree relatives get at any age. Earlier, it was 5 times.
Well, you're right, because different studies are going to come up with different conclusions. So that was the Memorial Sloan Kettering, which actually was an older study. This is a little bit more recent, and it picked it apart, I think, a little bit more. So I agree, you sometimes will see somewhat discrepant data just because you're looking at multiple different studies. Yeah. But I agree, that's a big range, double versus 5-fold. That's a big difference. Yeah.
So you're saying my brother would be at 3 times the risk, but my son would be at 4 times the risk?
Well, that's if there are 2 or more first-degree relatives. So does your son have 2 first-degree relatives?
No.
No. With prostate cancer?
No.
Yeah, so that would not be your son's risk.
So he'd just be at around 2.
Yeah, he would be probably this one is the best one that you can get. So, they're all pretty tight. You can see a range from about 2 to close to 4.5. And, it makes sense. The closer the relative, the younger the age, the higher the relative risk. Yeah. Thanks. Yeah.
Did I hear you say you multiply the relative risk times 12?
Well, if you use, it depends on what numbers you believe on this too, but the incidence of prostate cancer, the number I'm going with today is 1 in 8 or 12%. So 12% lifetime risk for prostate cancer just on average for anybody. And so then the relative risk, quickie way to do that is just take that number and multiply it by whatever these numbers are here. And some of these risks here, I'll get you in a second. Some of these numbers here are as high as if you had genetic testing, had a mutation, and were genetically predisposed. Having a 40% lifetime risk for prostate cancer would be an inherited predisposition. So this is just a different way to look at the numbers, like if you didn't have genetic testing, but you're looking at the structure of your family history and how many people had prostate cancer. Yes?
If a man had a sister who had a cancer in a corresponding organ, would he be at higher risk, or have any studies been addressed to that?
Yeah, in fact, I'm going to get into that in some slides I have coming up. So like the classic, connection of cancers would be prostate and breast and ovarian and, maybe pancreatic and melanoma. Those all are caused by the same gene. So if a man had a sister with breast cancer, especially if she was early onset or had other factors that made her look genetic, or maybe she had genetic testing and had a mutation, then yes, his risk would be significantly increased. But if he had had genetic testing, he could determine genetically, was he really at increased risk, or maybe he didn't get the mutation and he's sort of off the hook. Yeah, so this is really like no testing, where you stand. And I'm definitely going to go over several slides and case examples as far as testing. All right, looks like I can keep going. So this is just another, another way of looking at this relative risk. And so, you probably will see some discrepancies here that are a little different, from the other slides too. I liked this though. It was a publication in the Prostate in 2014. And what I liked about this is they asked clinicians to laminate and keep this in their back pocket, which I thought was really cute. I think that's something we did like in the 90s and early 2000s. And, now everybody's got an app for something, or, they're going online. But I thought it was kind of interesting because it's breaking it down like this column here, this group has a relative risk greater than 2, which accounts for maybe 26% of males. And this one has a relative risk of 3. So if you look over here, you see, more closely related people. You probably see people who are younger. My goodness, look at this, 5 or more second-degree relatives. So, more striking family history on the right side than what you would see on the left. So those are some nice little empiric data for you. And I know this talk is, I think, it's on the website, right? Yeah. So if you want to refer back to it, or if you need a copy of something, I'm happy to provide it. So now I'm going to shift gears and just talk a little bit more about inherited cancer predisposition. So you could basically make this pie chart for almost any type of cancer. We always say that at least 5 or 10% are definitely caused by, one high-risk gene that's very easy to identify. Whereas this group is what we call the familial cluster, where we can't find the gene that's causing it, but it sure looks like it must be genetic. And in those cases, we rely on the empiric data, the statistical data that I just went over. So this is my number that I'm going to go with, 1 in 8 men getting prostate cancer in their lifetime. But, of course, it depends on where you define lifetime, how high that number is or how low. And I also wanted to just point out this recent JAMA study, Journal of American Medical Association, that says prostate cancer now is considered one of the most heritable cancers. So there was a twin study where they looked at twins, like how many of, both twins actually got prostate cancer. And they found that like 57% of the variation in risk was attributable to some kind of genetic factor. So there's definitely a lot of genetics going on here. And I think prostate cancer is so common, and I'm sure you've heard people say like, oh, if you live long enough, you'll get prostate cancer. I don't know how you guys feel about that in this, thought on that? People say that though, And, I think that's a reason why prostate cancer, maybe got overlooked a little bit over time. So, who wants to come up and explain Gleason? I didn't see any hands raised. I'm assuming that you guys are experts on this already, but you're taking two samples, you're giving them a score, so you get like 3 + 3 or 3 + 4 to get your Gleason score. And Gleason 7 or higher, you're going to hear me say this a lot. I don't know, like in your clinical and treatment world, do they use that as a cutoff for anything? Yeah?
Borderline at that point,
Yeah, okay.
when you have something done and watch away.
Okay, yeah, so it's very useful in that way. So I'm going to keep bringing up Gleason stage 7 a lot too, because it seems to be a cutoff that's used a lot for genetics. So, if you have a Gleason stage 7 prostate cancer, or above, you're automatically a good candidate for genetic testing based on some of the guidelines. Yeah.
Is the treatment or outcome any different with inherited form versus non-inherited?
Well, that is a really interesting question. I don't feel like we have enough data to really answer that question yet. And but there are some really promising things coming down the pike. For example, like in ovarian cancer, we've learned that people who have BRCA mutations can really benefit from using a category of a drug called PARP inhibitors or Lynparza. And that's not really approved for other cancers yet, but it's going to be approved, I think, for breast. And you could almost see how that could be extended to prostate because they all have the same underlying genetic driver in those cancers. And so that drug targets that weakness.
Does the FDA know this?
I think they are very well aware. I think there's a lot of push. There's a lot of clinical trials right now pushing things to become, actual clinical information. Yeah. So that's just an example of how an inherited cancer could be helpful and insightful in determining the treatment. Okay. So I'm going to talk a little bit about some of the genes now. How many people have heard of BRCA1 and 2? Everybody. Oh, not everybody. Look at that. Some people. Mary Boatfinger has. So BRCA1 and 2 are genes that were identified in 1994. We started doing genetic testing in 1995. And, I think these genes have really driven a lot of what has happened in inherited cancer. And initially, the focus was really on breast and ovarian cancer patients. But, we saw along the way that there were other cancers, such as prostate, that were related and, began incorporating those when we're thinking about these genes. So sometimes people call them the BRCA genes because that's what the commercial lab calls it. I refrain from doing that because I don't work for a commercial lab, so I call them BRCA1 and 2. So early on, around 2010 and before, the guidelines with regard to these genes said something along the lines of, well, if you're a woman with a relative with prostate cancer, you should be aware that you could have an increased risk. Well, that was completely sexist because they were leaving out like half the population there. So eventually they changed it to an individual with a relative with high-grade prostate cancer. And then later, they started adding things like Gleason 7 or more, other cancers like pancreas or melanoma as well. So how many people have heard of HOXB13? Yeah, oh look, you have, right? In what context?
Reading when he was diagnosed.
Yeah, well good for you. Yeah, good for you. Well, this is an interesting little gene because it doesn't seem to be related to other cancers. It seems to be like a prostate cancer gene. And initially when this was identified, around 2013, the labs were like, ooh, we're going to put HOXB13 on our genetic testing panels. And they did. And then they found in 2014 that there was also some data that came out that said, this gene mutation doesn't seem as relevant as we thought. It seems very rare. It's only one specific mutation. So it was pulled off the panels, but it is actually back on. So it's kind of like a fair weather gene that goes on and off the panels. But, if I were testing, I would definitely include it. So another category of genes is called the Lynch syndrome genes. Has anybody heard of these before? Yeah? What do you know about Lynch syndrome? I like that. So she does not have Lynch syndrome, but it's a gene that comes to us more from the colon world because the highest risk is colon cancer, but it can also include prostate cancer along with many other cancers. So when we start building our menu of genes that we definitely want to test if you have prostate cancer or family history, we've got the BRCA, we've got the Hox, we've got the Lynch, and then, a couple others. So we're up to the point where there's anywhere from 12 to 14 genes where we can identify, these are inherited cancer genes that do have a prostate cancer risk. Of course, the risk varies. So a little bit more about HOXB13. It's what's called a homeobox gene, which basically means it binds something else and sticks to it, and it's a transcription factor. So it's important in genetics. It has a big job. But really, so far, there's only one or maybe two other specific mutations. So this is like somebody's mutation where an amino acid is changed to another amino acid. But it's like, less than 0.1% of the patients. So that's why the labs knocked it off, but then they decided to keep it on. Because there's a good 10 or 20, I don't know if I got to think about the math here, but 10 or 20-fold increased risk for prostate cancer. If you take 12% times 10 or 12, that's more than 100. So I can't see how that actually works. But it is one of the highest risk prostate cancer genes that we know of to date. All right. So I'm going to talk a little bit about, we call it HBOC, or hereditary breast ovarian cancer, but prostate cancer is definitely a part of this. So the breast cancer risk is huge. We're talking an 80% lifetime risk sometimes for some of these women to get breast cancer. The ovarian cancer risk is significant, can be as high as 50% depending on which gene you're talking about. And the prostate cancer risk, as you can see here, is, in this slide at least, estimated to be 20 to 30%. And what's interesting, so you've got in the pink, you've got BRCA1, you've got in the blue BRCA2. You can see that the BRCA2 is the one that tends to be more associated with prostate. Not to the point where I would only test BRCA2, but it's definitely more prevalent. And you can see the BRCA1 is more in the female breast than the ovarian. The BRCA2 has other things like male breast cancer, pancreatic, and even melanoma. So it has more different kinds of cancers with BRCA2. So next I'm going to show you a real family that I think illustrates this very, very well. So are you guys pretty good, like family tree pedigree readers? Have you had those kind of talks before? Yeah? So I'll kind of refresh you. So let's say this is the patient I'm working with. He's a 48-year-old gentleman, and he has a sister with breast cancer at 49, and look at that, 4 brothers with prostate cancer and a father with prostate cancer, and the ages are all listed there, and a sister who had already passed away from early breast cancer. Well, this is like a hit you over the head, no-brainer BRCA family, right? Something is going on here, and in fact, she has a BRCA2 mutation. We've also tested some of the nieces and nephews and kids. We had this guy come in and test negative, and we're assuming that she was positive, and we're assuming that he's positive because she's lived a long life with no cancer. So, he can go ahead and have genetic testing. Does anybody know what his risk would be for that gene mutation? What's that?
3 times.
If-
All his brothers.
Right. If you were paying attention to the empiric data, yes. But because this is what's called an autosomal dominant gene, so it's passed on, by men and women about 50% of the time to the next generation. So if he had the mutation up here, which we assume, then this guy has a 50-50 chance to have it. And what my favorite result to call out is, when you call this guy and you say, guess what? We know the mutation in your family and you don't have it. And, all of a sudden then they're at background risk. And of course they need to screen accordingly for background risk, but they don't have to think about basically following suit with all of these brothers. So, yeah.
I'm relatively new to this, so you mean to tell me that there was just a man who happened to walk through your door and just going to do some genetic testing on him and find this out? Or has he been diagnosed with prostate cancer? I don't know what comes first.
Right. It could be either. Like in my practice, I see patients who have cancer already, and I see plenty who just have a family history, but they're concerned about it. And
So they know it exists in their family, they're concerned, they haven't shown any signs, but
Right.
they want to know if they're genetically disposed.
Right, yes, 100%. Because, you know, in addition to the prostate cancer, if this guy was positive, he would need to be thinking like, what about my pancreatic cancer risk? What about my melanoma? What about my male breast cancer? So he would need to be on a comprehensive plan to screen or reduce risk as much as possible for any of those. And you're right, you know, we do not see many 48-year-old men just walk in with no cancer history, you know, asking about this. He was basically dragged by his sister to come in. So I think this gentleman was, you know, very willing and happy to do it. But a big motive for them a lot of times is, you know, he came in mostly because of his daughter to try to define whether she was at risk. And since he didn't get the mutation, there's no way he can pass it to his son or daughter now, which is, you know, a lovely thing also to find out.
In my case, I was diagnosed with cancer, prostate cancer. I had a prostate removed, and I was told that something was being sent out for genetic testing. Are you going to get into that?
I am, yeah. And I'm actually glad that you said that now, because it reminds me to say, like, everything I'm talking about right now is inherited genetics, things that come from your mom's egg or your dad's sperm that you can pass on to the next generation. But the last part of my talk is going to be tumor-based testing, just looking at the genetic makeup of the tumor and trying to determine what we can find from that. And they're really two very different areas, so it's a good time to just remind everybody. Yeah.
Are you going to discuss the drop down from, because I look at that chart and that's me.
Really?
With the brothers and then the drop down, well, sister at breast cancer,
Yeah, so what?
mother daughter breast cancer. So are you going to discuss how do we help the generation fall in?
Yes, I mean, I love that you said that because, you know, this generation here, I don't think they saw it coming. They were like, oh, dad has prostate cancer. And you know, most of the time, like above that grandparent generation, people don't even know what they had because people didn't talk about cancer. It was taboo. You know, you never really know. Your grandma just passed away. And so we're missing a lot of, you know, information up there. So there's a lot of information here in this generation, which can totally help this generation. So like, for example, these two young ladies who already tested positive, they're 25 and 32. Instead of waiting for mammograms at 40, they're going to get started right now in the early 20s with their breast screening. We'll also keep an eye on their ovaries. The screening's not as good as with the breast, but we'll do what we can. When they're 40, we're going to say, take out the ovaries to reduce the risk of getting that ovarian cancer. So yes, like this whole generation, males and females, I think there is, you know, something to be said for that.
So what do you do? What happens? You test them now?
Yes.
I've already gone past that generation. It's now grandchildren.
Oh, really? Wow. Okay. So we would basically, like in a family like yours, if we were just getting started, or a family like this, we would always pick the person who has cancer, who's the most likely person to carry the mutation. So that's usually the person with the rarest cancer or the youngest onset. But sometimes there's no one available, and we just have to start. You know, like in this case, we could start with him, but it wouldn't be as informative as if we had found that mutation. So the specific address of the way that the gene is changed is really helpful because we already know it in this family. So he's 50-50. We can test him yes or no, black or white, very, very accurately. And if he doesn't have the mutation, he can't pass it on. So I do think, you know, it's good to work with those next generations and start with the younger people. But you can bring a horse to water. And, you know, not everybody is going to really embrace genetic testing. I think there's a lot of fears and concerns about it, a lot of psychosocial issues, too. All right. Any other questions before I move on? Yeah.
This doesn't apply to the majority of people in this group. Did I hear you say that peritoneal cancer is connected?
I think I said pancreatic, but you're right that primary peritoneal carcinoma, which is basically a woman has had her ovaries and, lady parts removed, and there is cancer that develops in that body cavity. And so, it's the theory is that there are cells that got left behind from the ovaries, and that cancer develops. And that is a very rare cancer, and when we see it, we automatically think about genes like BRCA1 and 2, for sure.
Because my mother died of breast cancer. Long before that, she had 2 sisters, her older sister died of spontaneous doctor, because in those days,
Right.
peritoneal or stomach.
Yeah.
So now it's making me more nervous because
Well, I always encourage you probably won't get medical records anymore, but you could go get a death certificate and see what's listed on that. But, those are not always perfectly accurate either. It might give you a little bit of information. Yeah. I think most people aren't that picky. Like, if you have some red flags for an inherited cancer, you're a good candidate for testing. I myself am a very generous tester, but we have to work within the confines of what an insurance company will pay for and so forth. But I think even today, like, insurance companies are very generous compared to what they started out with in the 90s and 2000s. Did I see a question over here?
So the guy at 48 will say he does not have the BRCA
Right.
gene.
Mm-hmm.
What's the chance of his son still getting prostate cancer? Is it 2? Is it 1? Is it almost
It
0?
would be the background rate. It would be the 12% rate, 1 in 8.
1 in 8.
Yeah, that's as low as I can go unless you remove this prostate.
Just extremely low.
Yeah, as low as possible. So, he basically would have like a normal copy of 2 genes, so he has nothing to pass on. Of course, we look at his spouses, the kid's mom,
Yeah, right.
side of the family too. Yeah, that's a good question. Thank you. All right. So next. So here's where things really were until just this past fall. I mean, not even a year ago, really. If you were a man and you wanted to have genetic testing, you had prostate cancer, we would say, well, do you want to take, one of our breast ovarian panels, or maybe you'd like to have one of our gynecologic panels, or a bigger one called MyRisk. So what's wrong with that? Like, you're a man, you don't want that, right? You want a man panel. So us genetic counselors, we are like, okay, the prostate, cancer panels, we are considering those like the man panels. Even though they do, have still risks associated for the females in the family, like with breast cancer and so forth. But I think we've been able to really vet out specific genes that are targeted towards prostate cancer and, offer people testing for that. So I'm glad you liked my man panel joke. But it's definitely, I think, where we're heading. So we're getting away from this and, offering you something that's more specific. So this is, in my mind, a very landmark paper. I don't know if any of you have heard of this. This is Colin Pritchard. He works for University of Washington in the state of Washington. And it was published in New England Journal of Medicine late in 2016. And this is basically the study that says, wow, look how genetic or inherited prostate cancer can be. So he had 692 men who all had metastatic prostate cancer, so more advanced. They were unselected for family history or age, so it didn't matter. They could be 80 years old and have no family history. They were still in this group. He did testing for 20 genes, and he found in about 12% of them, he found a mutation. So that's actually really high. When we do genetic testing on a clinical basis in our clinic, we'll usually look for somebody who's about 5% chance of a gene mutation or higher, and that's where we'll start offering. So basically anybody with metastatic prostate cancer, regardless of age or family history, has now become a good candidate. At least, statistically, knowing that there's a pretty good chance that you're going to find a mutation. Now, if you only look at the localized prostate cancer patients, the rate drops pretty dramatically to 4.6%, so it's a lot less. And, you probably wouldn't jump into genetic testing just based on that. You would look for something else, like early onset or family history to trigger. Yeah?
Does that suggest that there are 2 different types of cancer involved? The metastatic versus localized?
It does, and I think it also suggests that underneath the people who have these inherited mutations, their cancer development is sort of one step ahead of everybody else's, through the progression to become cancer by having that mutation that they were inherited with. Yeah, so, it's a biased sample. It's certainly not 100%. It's only 12%, but it's significant, really. So this was the landmark baper, and in the next slide, I'm showing.
Question?
Yeah, sure. Go ahead. I'll go
Say
back.
11.8 mutation. Is that the same mutation or is it any mutation? Is it,
I'm glad you asked. So it could be. Oh, I should move back. It could be any of these on this pie chart. So remember how I mentioned BRCA2? Well, this is like the #1 gene that causes an inherited predisposition to prostate cancer. And then some of these others like ATM and CHEK2, I'm certain you probably have not heard of these genes because they're kind of newer and more moderate risk, but they do have a big component in the prostate world. So these are kind of, some of the heavier hitters here, and I don't expect you to remember the names of them because it looks like gobbledygook, I think, to a lot of people. But it gave us like a good list of genes based upon this landmark paper of these are the genes that we think about when we're talking about inherited prostate cancer.
so some of the mutations are worse than others, you would say.
Yes, I definitely would agree with that. I've got a table coming up that'll show you some of the different genes and how much the risk is increased because some of them are 40, 50%, some are like 10% increase. So big difference. Good question. So this is just one of the genes, or one of the labs that started offering prostate cancer-based testing, a panel. So when I say a panel, that basically means like we're testing all of these genes at the same time. So I think Mary Bofinger could agree, like back in the olden days, we used to just test one gene and then we would test another one. And now, you could call this a shotgun approach or whatever you want. I call it kind of fishing. It's kind of like we're throwing out a big net and we're looking to see if we have mutations in any of these genes. So it's a panel test. But you can see there's overlap with all these different organs here, with these genes. So even though it's a man panel, it still has some female cancer risks associated. So that's Ambry Genetics. This is from the lab called Invitae, so another commercial laboratory that does testing. They're quoting a lot of the same statistics here, which I thought, but I like this one, that patients with metastatic prostate cancer are 4 times more likely to have a BRCA1 or 2 mutation. So I thought that was kind of helpful. And they also felt, in this study that the family history alone cannot predict. So you can't just look at the family history, that it's really the more advanced status of the cancer that is predicting the likelihood of an inherited mutation. So that's Invitae, and they have, this is I think the table I promised you earlier. So this is a list of their genes, on their prostate cancer panel. And then these are the elevations of risk. So you can see like HOXB13 is definitely, the highest, but it's also the rarest. You're the least likely one that you're going to find. And then, there's a range of, 20%, maybe up to 30%. And then there are some where we just don't really know. Like we know it's maybe elevated statistically, but we don't have a good number to put on it, excuse me. All right. And then just, so you know that there are more than these labs. This is a little slide that came from GeneDx. And I guess I want to remind myself that I have handouts on the chair there. If you want to pass them around, like they're to your left. The big shiny ones, yeah. It has basically this table. And I like this table a lot because it shows the different genes and then it shows like which kind of cancers also go with it. And it's broken down into like high risk genes, moderate risk genes, and then new genes that we, really still need to learn a lot about. So it's a nice way to look at it. But I think any of these labs, the tests that they offer would be very reasonable panels to run on somebody who came in either with a family history or who had a metastatic prostate cancer. Any questions before I go on? Yeah.
There are a lot of labs that run these tests.
There are.
Like, I've already had the Polaris test.
Mm-hmm.
I know there's an Oncotype DF or something. all test the same 12 or 16?
No. It's interesting because, I don't want to explain that. These genes are carefully vetted that we know that if you have a, what we call pathogenic or, a serious mutation, a high-risk mutation, it is going to lead to a predisposition to cancer, a higher risk, but nowhere near 100%, as you can see, just a predisposition. When they're testing the genes that are in the tumor testing, they're not necessarily testing these same genes. In fact, they're quite different. There's a little overlap, like a few are the same, but for the most part, they're different. And the reason that they're different is they're looking for what's called an oncologic driver, something that's basically getting into the cancer, a gene mutation that's getting into the cancer and it's driving it, it's pushing it to become, more aggressive, more metastatic, and more advanced. And so they're slightly different genes, although there are a few overlaps. And I'll explain that a little bit more. I'm so glad that you had Prolaris because I have some slides about that, and so you can come up and explain it. That would be great. All right. So, bottom line, there's plenty of labs that want to do this testing, commercially for you, and that we have really good success in billing for insurance in general. I will say I think prostate cancer is a little bit behind other cancers, no fault of yours, of course. But a breast cancer, ovarian cancer patient, even pancreatic could probably come in and, have an easier time getting the pre-authorization for the testing than a person with prostate. And that's because right now Medicare, they'll include if you have breast cancer or colon cancer and a significant family history, oh yeah, they'll pay for your testing 100%. But there's nowhere on do you have prostate cancer or not? And it's definitely a crack that people could fall through. And I hope it'll change. I think the insurance companies usually take a little while to catch up to what we're trying to do in the clinic.
If you're already diagnosed, I'm sorry. Go ahead.
I just was going to ask, where are your referrals coming from? Are they from the individual patient, from urologists, from internists, from...
A wide range.
Yeah. Primarily? You would think the urologist, but probably not.
Yeah, we've actually been working with the urologist lately, and we're writing something that's called the white papers. I don't know if you're familiar with that, but basically institutional guidelines that say this is what we're all going to do, and we're including criteria like this of hey, if we see a gentleman who has metastatic prostate cancer, then he's a good candidate automatically for genetic testing. So we're trying to write those things in there.
So you're going to talk more about tumor mutations.
I am, yeah. Keeping in mind that that's my lesser area of experience. Yes?
Tell us a little about the money involved.
The money, yeah. So I feel like I have seen it all now. And back when I started doing this in 1994, 95, genetic testing was not covered by insurance companies, and people would come with thousands of dollars of cash and money orders and asking to do false names and stuff like that. Just crazy town, really. And so thank goodness things have gotten a lot more stable and a lot more comfortable. There was a law that went into place in 2008 called the GINA law. It went in alongside with HIPAA that basically says a genetic testing result is not a pre-existing condition. You can't be dropped. You can't be charged more money. You're guaranteed portability to another insurance company if you have a mutation. And that all of a sudden made people feel a lot more comfortable with genetic testing and having that information out there. With regard to billing for the testing, so that's another area where people need to get comfortable. Most of these tests I'm showing you, if you were to self-pay for them, they would be about $1,500, 1500. And my husband says I can't say only, so so 1500 is kind of most of these tests that I'm showing you what they would cost. But most of the time we can figure out a way to get it covered by insurance these days. We've got this great data, we've got that landmark paper that's showing us there is a risk. A lot of times people have a family history, already, maybe of breast or ovarian or pancreatic or colon or something else, that can help us fight the good fight with the insurers. But every time we send a test, like if you come into me and we decide like, okay, we're going to send out a test, we do the informed consent, we sign all the papers, and we send out a blood or a buccal sample to do it, when we send that, we're asking the insurance company to work with the lab and do a pre-authorization at that time. So if I took Kurt's DNA and I send it out by FedEx to the lab today, then tomorrow they're going to stick it in the freezer at the lab. And in the meantime, they're going to take all the information that I've given them, like the ICD-9 codes and the family history and all that, the indications for testing, and they'll do a pre-authorization. And so we have kind of learned like which labs work better with which insurance companies and which situations. So, I don't send to just one lab. I send to all these different labs because I've learned how to get the best outcome for the patient. And so the labs typically will call you if for some reason they cannot pre-authorize your sample. If you have any out-of-pocket cost over $100, they will call you, and they will say, hey, Kurt, your out-of-pocket cost is going to be $450 on this. And then Kurt can say, well, I'd like to ask for financial support, which I recommend for everybody because they give it to everybody. And then they'll say, okay, well, let me, learn about your financial situation a little. And now, okay, your out-of-pocket is going to be $195. And then if Kurt says, okay, I feel comfortable with that, I accept that, then they'll go ahead and activate the test. Or Kurt can say, I'm going to cancel the test. Never mind, I don't want to do it. So I feel like patients these days have a lot of control. You can know what your cost of the test is going to be before it even gets run. And I really think that we're on this tremendous improvement pathway of insurance companies understanding that, hey, remember that 48-year-old guy up there? It's way better to offer him genetic testing and find out whether he has this mutation or not so he can be more careful about his cancers that he's at risk for. A lot cheaper to do that than treat him, later with chemotherapy or surgery or what have you, which is very expensive. Yeah.
So if we've already had prostate cancer, why would we get tested? And then our kids that need to be tested?
I love that you asked that question because I hear that a lot. So my goal as a genetic counselor, if I'm going to solve the mystery, of what's going on in your family, if I tested, do you have sons, daughters?
Both.
Both? Okay. Well, so let's say I tested your son. And how old is he? One of them. 40. Okay. So he's at a very good age, I think, to be considering that. So if we tested him and he had a normal or negative result, it doesn't really tell us whether he is off the genetic hook and just didn't get the mutation, or is it a mutation we couldn't find, or is it there's no mutation in the family, in which case he still could have a statistical or empiric risk that's increased. And so it wouldn't be quite as informative as if I tested you and I said, oh, look, you've got this HOXB13 mutation at position 84 in the gene. Now we know the exact address where this is in your family. And now, at a much lower cost, usually about $300, we can go through each family member that wants testing and say yes, no, who has it, who doesn't. So that's what we call informative testing. But to get to informative testing, we have to test the person that's most likely to have the mutation, and that is typically somebody who has had cancer themselves. That answer? Yeah. But
In his case, then, is it $300 for his son and $300 for his daughter?
So the first person in the family who has like the big panel test, that's the $1,500 test. And if you find a mutation, then you've narrowed it down. You don't need to test all those genes. You've pinpointed which one we think it is in the family. And then everybody else who's at risk would have the lower cost, the $300 test. And if it makes sense sort of like this way, like if I said, hey, I'll meet you over on the west side of town in an hour, okay? And I drive over there and you're trying to find me, you have no idea where I am. But if I say, hey, I'm going to be over at 123, Main Street, and here's the zip code, that's kind of like knowing the mutation. Like you know exactly where to look for me if I'm the mutation. Does that make sense? Okay, good. That was a good question. I'm glad that you asked that. You guys have the best questions.